Gabby, if you want to, you can go ahead and start.
Yes, thank you, Jen. I agree. Just introducing everyone and hearing everyone's story and where they are in treatment. I think it's encouraging to interact with people who are further along with you, or further along than you, rather, in your experience, which is very exciting. I am a cancer survivor myself. So I had Hodgkin's lymphoma. I'm 6 years in remission, but cancer diagnoses and treatment is very, very close to my heart. So I'm actually very honored to be here talking with you ladies today. I think you are stronger than you will ever know, going through your experiences every day. Just to, like you said, you made a point actually, or where have you gone? I think it was Tracy. Yes, Tracy made a point that she was, oh no, it was Tracy, that she is just, so happy and so grateful to be here. And I think we all are in that mindset of just being grateful for every day. But the purpose of my talk today is to discuss, the side effects that patients undergo during treatment, other than the cancer. Medicine has advanced so amazingly that we now have so many patients who get to that stage of survivorship. You would hear cancer back in the day and it would, automatically feel like a death sentence, but that's not the case anymore. And what we're seeing now is that it's not just about treating the diagnosis, but patients as a whole. You're there long before the cancer occurs in your body, and you're there long after. It's about holistic treatment, more than just the primary diagnosis. So my aim of the discussion today, my hope is that patients will see that they're not alone in their experiences. Something that I might mention might be common for a few of the women on the chat today. B, I want to discuss the power of exercise and functional activities, how they, the power that they have throughout the treatment process. And lastly, just how you're able to empower yourself through physical exercise. When you hear that diagnosis, there's a loss of power and there's a loss of control. And I feel like patients need to regain that part of themselves. This diagnosis hasn't taken control of your life, and physical exercise is one of the main areas that you're able to do that during this time. We have so many women walking around, and I'm sure a lot of our people in the group today will say, the ones taking hormone blockers, there's a lot of chronic pain, there's a lot of joint stiffness, discomfort, and even post or during chemo, patients experience things like neuropathy, which we'll go into a bit of depth later. But up until now, physicians have kind of, prescribed medication or said it's okay. This is just what you've got to live with, or it will improve with time. But we don't want that for people. You've been through this ordeal as is. It's about having an improved quality of life, to be honest. And especially our patients on the hormone blockers, it's disheartening to hear that, oh, you've just got to live with the stiffness, or this is your life for the next 5 or 10 years. You actually don't want to take the medication. And we want you to be as compliant as possible, but it has to be an equal balance between quality of life and medication compliance. A lot of the international oncology rehab discussions that I've attended in the past year all say that they have a goal for physical therapy to be part of primary treatment for all cancer diagnoses by 2025. So they are working on that. That is really, really exciting. Studies are showing that patients who engage in physical and functional activities from diagnoses throughout treatment have less run-ins with possible side effects, but also later conditions in life, like secondary occurrences, things like other chronic illnesses. And I'll get into that a bit more shortly, actually. But it's about shifting our doctors' mindsets to seeing beyond just a secondary diagnosis of lymphedema. I often get patients referred to me with lymphedema, and we find that there's this whole other list of problems that they've just been living with, but because they haven't known that there's this option of exercise and physical therapy, this is their new normal, and that's not okay. That's not what we want at all. So just to throw some statistics out there are 44 million survivors worldwide, due to a study taken in 2019. So we have 44 million cancer survivors worldwide at the moment. 2019 statistics showed that 18.1 million people were newly diagnosed in the year, and 70% of those 18 million present with physical side effects 1 to 10 years post-treatment. Just to get into a bit of those side effects, let me open up my file here. Okay, so there's a demand for oncology rehab services. Number one, due to the increase with the number of people diagnosed with cancer, early detection, better awareness, things like that. We have an increase in number of people living longer and surviving their treatment. There's greater awareness of the long-term effects, and we're now starting to include more people into the scope of practice. So, you know, you're not treated solely by your oncologist. You often have your surgeon. Sometimes there's a plastic surgeon involved. You've got your radiology oncologist there as well. We're starting to look at things like nutrition, physical exercise, the psyche of things, you know, either going for counseling. And then, of course, you've got your support groups like this, like the Breast Health Foundation is absolutely phenomenal in organizing and empowering women to speak out, to chat to people who have been through similar experiences. And we can't underestimate the power in that, because it really, really is powerful. So let's start at the beginning of your journey. Most women, most patients start with what we call neoadjuvant chemotherapy, which is chemotherapy that you receive first before you start your surgery. Okay. Generally, patients experience a multitude of symptoms on chemotherapy. Number one being the most common, fatigue. And I think that impacts function a lot more than anything else. When you're tired, when you're in that state of feeling so low, when your immune system's down, you really don't want to engage in your normal, what we call ADLs, your activities of daily living. So you don't want to eat and socialize. A lot of work. A lot of patients find it hard, feel like yourself, doing things that you enjoy, finding a hobby that you enjoy, taking up walking. Walking is one of the best forms of physical exercise.
Gabby, are you there? We're battling a little bit with connection. I think Gabby's connection might be a little bit bad. She might have dipped. Hello, Gabby, are you there? I think she might have left us to...
Sorry, I just got kicked out.
Oh no, sorry. So your connection, I think your connection dipped.
Yes. I just wanted to check that, but I think everything is in order now. I'm sorry, I was talking to myself for quite some time there.
No, not at all.
Not
at all.
Okay.
So if you can just go a little bit back and then carry on.
Okay, so we were just discussing neoadjuvant chemotherapy.
Yes.
Did you manage to get that in?
Yes, and then from there.
Okay, awesome. So with the type of chemo regime that breast cancer patients receive, there's various systems in the body that are generally targeted with that type of chemo. So number one is your nervous system. Patients often complain of pins and needles in their hands, in their feet. We call this chemo-induced peripheral neuropathy. And essentially your nerves are just almost on fire, to put in layman's terms. They are so irritated by the chemo, you know, running through the course of your body, that they become hypersensitive and sensitive to things like touch, sensitive to things like temperature. And it's very actually hard to pinpoint when you get that tingling feeling or that sharp shooting pain. Some patients live with it chronically, but it's quite frustrating. And if you think about it from a functional point of view, if you've got continual tingling in your fingers and your hands, or even numbness in your hands. It's difficult to do fine motor tasks like buttoning up your clothes, things like opening bottles, to use in the bathroom or for eating, judging whether things are hot and cold. That can all impact areas of, cooking and things like that. So there are treatments available for chemo-induced peripheral neuropathy. There are studies running now for it's a type of therapy called deep oscillation therapy. Essentially, what it is, it's a vibration set at a certain frequency, and therapists that are trained to do it basically massage over the arms and the legs, and they dull down the nervous system just until your nervous system is able to, basically regenerate and get back to being in the norm, if that makes sense. Secondly, with chemotherapy, neoadjuvant chemotherapy, patients feel a lot of nausea. We get patients with quite a bit of GIT problems, so either constipation or they can't stop running to the bathroom. They then lose their appetite. They get a malabsorption of what they're eating, then malnutrition. So we get a lot of patients with malnutrition, eating the wrong things, just to try and get, sugar and nutrients into their body. So that's kind of where your dietitians play a key role. Looking at what you're taking, looking if they can prescribe like a probiotic or something, just to get your gut health back to normal. It's quite frustrating as well. If you're not getting enough food in or substance, your energy levels are also going to be quite depleted. Then we look quite commonly with what we call chemotoxicity, cardiotoxicity. So the chemo regime that's prescribed for breast cancer patients can play absolute havoc on our cardiac health. And that is often why doctors ask patients to go and see a cardiologist either before or after treatment, just to kind of check overall health, heart, and well-being. Studies show that patients who do low resistance training prior to starting their chemo diagnosis, they respond better on treatment. So they have less of these side effects, and their heart tends to cope better with the treatment. Of course, though, you have to be extremely careful when you are exercising on chemotherapy. We go according to something called the rate of perceived exertion. And based on where a patient is in terms of how far since they've had chemo, we kind of like patients to monitor their heart rate and what they're doing in that time. So Karen, you mentioned that you are halfway through your chemo cycles. Congratulations. I hope that you have been feeling well, not too ill during them. But if we had to look at a rate of perceived exertion for you, you would be on a level of 1 to 3. Okay, so activities would be very, very light. It would be activities where you could continue conversation throughout and feel like you could do it the whole day, basically. So we're telling you, exert yourself, but to a point where your heart rate doesn't go above 90 beats per minute. That's your peak rate. Okay, for our patients who are in their stage of, using hormone blockers, that's been a bit more time since you've had chemo, if you even did have chemotherapy. And then you can do kind of moderate to very hard exertion. So your usual kind of exercises that you would do. We wouldn't necessarily worry too much about strain that you'd be putting on your heart because you're out of that window of the cardiotoxicity. Then comes surgery, and you can imagine now, patients often say to me that they didn't expect their outcome after surgery to be what it was. Because you think it's just breast, you're not really going into any of the major muscles or joints, but your breast tissue sits predominantly on this muscle over here, our pec major muscle, okay? And that muscle attaches on our clavicle up here and on our humerus bone over here. So any shoulder movement, even if you're not using that muscle as a primary muscle, it's a secondary muscle, okay? And that muscle is quite agitated after surgery. You also have that muscle sitting on your rib cage. So some women complain of rib pain after surgery. When you're in pain, you naturally go into a defensive kind of positioning like this. So you hunch over, you tend to bring your rib cage up. And then we end up with very poor posturing. We end up with stiffness, joint pain, and our mobility isn't what it should be. So one of the most common things, post-surgery with the patients that I deal with is they're not too sure what they can and can't do in terms of function, essentially. What I generally say to them as we go along the phases of healing, So the first 2 to 3 weeks post-surgery, we kind of just want the tissue to settle. We want stitches to heal. We're not so worried about mobility just yet. And it's not a long enough period for anything like contractures to form at the shoulder or muscular contractures in the pec. From the 3rd week onwards is when you need to start being more functional and more mobile. Okay, so before I move on, I don't want patients to sit, still like this during their surgery, because then you run the risk of things like lymphedema. You should be using your arms within a pain limit. So ideally, the 2 movements that you want to avoid post-surgery is shoulder external rotation and abduction. So I'll just demonstrate those. Abduction is up like that. Okay, and external rotation is if you bend your elbow in a flexed position and twist back like that. Okay, those are the 2 kind of functional movements that you want to avoid post-surgery, just because your pec muscle becomes quite a main muscle in that movement. For patients who have lymph nodes that are removed, I know generally with Professor Ben, she is absolutely amazing at removing lymphs, and she will never take out more than what she needs. For patients who are being treated elsewhere, it's important to have that discussion with your surgeons to find out how many lymph nodes they are removing, and to possibly then look into lymphedema if you are at risk for lymphedema, and then to seek out treatment as soon as possible. Okay, I'm going to discuss lymphedema in whole as just a different section because it is still quite prevalent for our breast cancer survivors. So yeah, you've got to, move within your pain limits post-surgery, and then 3 weeks post-surgery is when you kind of can get back into your functional activities. Patients ideally should be driving only from 3 weeks on, depending on your work that you're doing. I know we have a lot of patients that are mainly office-based. So sitting at their computer all day, typing, writing, things like that, you're still putting strain on yourself in that position. Okay, you're putting static strain. So even though you may not be lifting heavy things or moving things around, sitting in that position is still, causing strain to your back and shoulder muscles. In terms of sleep function, we have a lot of patients that have interrupted sleep because you are used to sleeping on your side or on your stomach. Now all of a sudden you have to be super glued onto your back, and that's quite uncomfortable for some patients. So what we try and do is recommend to change how you sleep in terms of position and supports and what you use to try and make it easier for you. So if you are still sleeping on your back, what you're going to try for me tonight is to have 2 pillows underneath your arms like this. Let me just tilt my camera down so you can see. You're going to have a pillow on each side holding like this. Okay, what that's going to do is when you need to get up, you've got something to hold onto to pull yourself out, but you're also giving a nice gap between your underarm, your axilla, and your chest area. So if there's any swelling, if there's still wounds that are healing there, if there is any signs of lymphedema, you've got a nice kind of gap to keep your arms over your pillows like that. Okay, and then you're going to put a pillow just underneath your knees. What that does is you're increasing the amount of surface area of your body lying flat, and you're alleviating weight and pressure bearing on your lower back. Okay, if you're side sleeping, I want you to do a similar thing, and that you're going to keep a pillow underneath your arm there. So you're going to hold a pillow between your arm and your chest wall, and then a pillow in between your knees so that your knees aren't pushing onto each other and your weight bearing onto your hips like that. Okay, so if you are having issues with sleeping, you can bring up a question about that and we can discuss it a bit more in depth, personalized to you, but that's generally what we tell patients to improve sleep function. Let's touch on work a little bit. So depending on if you are self-employed or working for a company, generally patients, ask for sick leave, and employers are generally happy to accommodate them. Unfortunately, we do have situations where patients are on a limited amount of sick leave or they're expected to go back. Can be any what reason why you are having to go back into work. What I would recommend is to just reach out to an occupational therapist. So we are generally vocational trained, and in that we can do a full kind of work assessment and write a letter to your employers. They do accept them kind of as, cool, let's take this and let's take their word for it. There are times where patients just do have to go back to work and we just have to push ourselves into it. From a psychological perspective, I think it's also very difficult to have gone through this kind of experience and then be expected to go back into normal life. I know personally for myself, it was, where's my adventure? Why do I have to go back into studying and just live, everyday normal life? I was very, very rebellious towards that idea, and it took a while to kind of just get back into the stage that, life goes on. And that's why I think it's important that even from your early stages, even from chemo, to keep your life as normal as possible. Doing things that you did before the diagnosis so that you don't lose that part of yourself to this experience. After surgery, our patients sometimes have chemotherapy. Sometimes they do surgery first and then chemotherapy second, or they go straight into radiation. Okay, there's generally a 6-week waiting period between your surgery and your radiation, just to kind of let the tissue settle, let the breasts heal, and then it's time to radiate and really get rid of any kind of cancer cells floating around in the body. Now, I don't know if you remember, but earlier I said the 2 positions that you shouldn't do post-surgery are shoulder abduction and external rotation. But when you go in for radiation, those are the exact 2 movements that you have to do to lie in the machine. Okay, they prop you up lying on a bed like this with your arm above your head so that they can radiate the margins of the breast, depending obviously if it's the left or right or both sides. But patients often find that it's really uncomfortable for them. If you're going for 30, 35 radiation sessions, after a while being up in that position every day for a few minutes is really going to start to hurt at the shoulder. Okay, if you are doing functional exercises and activities and you're keeping those joints, that shoulder joint rather stable, you're keeping those those muscle attachments nice and strong, you're not going to run into these problems. I see patients who are compliant with exercising from, post-surgery all the way through radiation. They fly through it, which is awesome. Some patients who are more idle are the ones that tend to get that joint stiffness and the joint pain. So it's important that you are, finding out which exercises are right for you based on your period of treatment, what you should be doing to really prevent these secondary complications from occurring. And then last but not least, are patients who are hormone positive. That means ER/PR positive cancers. They are prescribed a hormone blocker for 5 to up to 10 years, just based on their diagnoses and the nature or the pathology of their cancer in essence. The function of your hormone blocker is to basically deplete estrogen in your body so that if there are micro cancer cells floating around, there's nothing for them to feed off of and grow elsewhere. So it's a fantastic drug. It's very targeted. It's not like your systemic chemo that affects multiple systems in the body. It really just targets your hormone production. But unfortunately, as women, estrogen is a vital hormone for a lot of body functions. And when we deplete it, we present with a lot of physiological side effects and physical side effects. So number one, you have your hot flushes. Sometimes women complain of extreme mood swings, so feeling very low, very depressive, sometimes very short-tempered. That's me on a general day. So yeah, I don't know if that's really one thing that we can complain about. We have joint pain, joint stiffness. We have patients complaining of arthralgia, which is arthritic-like pain. And that in a whole can affect function entirely. If you're thinking about joint pain in your hands and your elbow and your shoulders, that's all function in your upper limb. If you're thinking about joint pain in your hips or knees, that's your ability to walk and be mobile. And, being able to move around is one of our greatest gifts. Being active, whether it's a walk, whether it's getting up, going outside, whether it's gardening, doing things that you love are impacted because you have this joint pain and stiffness. So how we treat that from a functional point of view is obviously to encourage our patients to engage in all of these activities. If you don't have something like that, to source a hobby that's best suited to your lifestyle. So exercise for patients that are on hormone blockers should also be low impact. So nothing like boxing, weightlifting should be very low weights. You should be doing kind of more long stretching, soft stretching like yoga. Sometimes a bit of Pilates is also really good. There's a few courses online. There's YouTube channels that you can look up and join, and they do a lot of things like Tai Chi. Tai Chi has shown massive benefits for patients with arthritis. So for us, it would be more the arthralgia pains and things like that. If you're looking at temperature therapy, so joints also respond really well to temperature. If you're experiencing joint pain without swelling, you are advised to use something that is warm, like a bean bag. Bean bags are fairly easy to make, actually. All you need is like an old sock or an old pillowcase, fill it up with uncooked rice, stitch it up, and that heats up really nicely in the microwave, even in the sun. If you're experiencing joint pain with swelling though, and you apply heat, it's not going to do much for you. It's going to actually make that pain worse because you're increasing blood flow to that part. You're going to want to use something cold rather. And I know when you're in pain, you think something cold, that sounds horrible, but you'll actually experience more relief using the cold than you will the heat in that instance. Building up joint strength, tendon strength also really helps that joint mobility in a whole. If your muscle attachments are nice and strong, they're going to aid that joint in mobilization and stability. As you know, we can't really work on, bone strength and bone growth. But just touching on that, it is really important for our patients to monitor their bone density while they are on hormone blockers. If you are taking any supplements, I would advise that you discuss it with your physician, your treating physicians first, just to make sure that you're on the correct medication. But your two most important supplements will be your calcium and your vitamin D. Okay, those are your most important for your bone building blocks, essentially. So if you're not taking any of those supplements, or you'd like to find out about that, I would just chat to your treating physician to give you more information on the supplements that you can take. But it is about looking at the bigger picture as a whole, looking at yourself as a whole, and making sure that you are as functional as possible during treatment, and making sure that you are as active as possible. Again, just some statistics. What they're actually trying to do is work on a concept of prehabilitation. So patients that, as they get their diagnoses, are then seen by a physiotherapist or an occupational therapist, and they discuss basically, what's gonna happen in the next few weeks to come, what's gonna happen in the next few months to come in terms of treatment, what they can expect. It's not really something to bombard the patients with information, but more just to give them a bit of empowerment back that yes, you've been diagnosed, but we're still going to be functional, we're still going to be proactive, and we're still going to move during this time. They've shown that physical activity can reduce the risk of cancer mortality, so cancer death, by 37%, and physical activity can reduce the risk of reoccurrence versus the risk of reoccurrence in a less active patient by 35%. So those numbers are slowly starting to increase as we get more patients proactive about their well-being and their health. And it's fantastic to see, actually, that, instead of having to go for doctors for continual painkillers, we're seeing lifestyle adjustments, we're seeing lifestyle changes in patients, taking charge of their own health through nutrition and through physical exercise and function. And that's all that I have to share with you from my side. Thank you, ladies, so much for listening. I really appreciate you joining in this morning. I hope that it's something that I came across or had something of value to some of you. And if you have any questions, I'm more than happy to answer them.
Great. Thanks so much, Gabby. That was really, really interesting. I learned a few things there. That was great. So, ladies, who's got questions? Questions, anything? Nix, I see your hand up already.
I just wanted to say to Gabby, having been, done cancer exercise myself, and I came from an athletic background, so I was fit going into my surgery, and I had a really very quick recovery, and I was exercising pretty quickly afterwards. But I think it's also so important going into survivorship and for the patients to maintain exercise and the quality of life. While you're going through treatment and you've got all the support of your surgeons and your oncologists and your physios and doctors, you can't go on with that endlessly. And when you get into survivorship, obviously that comes to an end. And then I think, the big thing with cancer exercise is to try and promote it, into survivorship and make it consistent, because it's so important, the consistency. And, I think what I've found is for each individual person is to find their own specific modality of exercise, and I think that's so important. And then to also have a goal, because if you don't have a goal that you're working towards, then you just give up. I mean, normal people, that going into exercise find it hard to maintain and to start that. So I think that is just so important as cancer exercise specialists, and to just to support the patient. A lot of people find it difficult to do alone. So like, as you say, to be in support groups, or have group exercise if you're not the kind of person that can do it alone. But I think there's just such a big market out there for cancer exercise, and to promote for cancer.
Definitely. I completely agree with you, Nicole. And I mean, in your training as well, it's about, giving patients insight as to what's aware and what's available for them to do. Not everyone's going to become a comrade marathon runner after treatment, but if it's just a general walk in the park with friends, or if it's the goal of being able to walk 2 kilometers without feeling breathless afterwards, it's it's tailored to you. I think what Nicole said is absolutely brilliant and on the nose. It's about having goal-driven exercise, or purpose-driven exercise goals rather. So thank you, definitely.
Great, thanks, Nix. Okay, ladies, anyone else with questions, comments, a particular question about what you couldn't do? Karen.
Yeah.
Obviously, still got to say all the surgery and all that stuff. Somewhere, can you guide me?
Karen, sorry, I'm just going to interrupt you. I'm struggling to hear you.
Again?
There we go. That's perfect. Thank you.
Sorry. So I'm still got to face all the surgery and all that side of it. I'm trying to find somebody I can talk to, different people I can talk to who have had surgery, I'm trying to find different options so that I can prepare myself with different options. Is there a group? Is there
absolutely
people I can talk to?
Yes, so there is. Sorry, Gabby, I'm going to answer.
Take over, please, Jenna.
So absolutely. I mean, this is kind of one of it. And we've got lots of ladies that have obviously been through this journey as well. So maybe what you can do is you can just send me a message, Karen. And then what we'll do is we'll buddy you up with a breast cancer survivor that has been through their treatment and has had a similar breast cancer to you. Whether it's, hormone positive, HER2 positive, had chemo, not had chemo, etc. So if you just send me, I don't know if you have my number, I'll quickly send it through to you in the chat. And then we can buddy you up with someone. Okay. And then there is kind of forums like this, our Bosom Buddy forums. We've got lots of videos and stuff like that online as well. And I don't think you're on our WhatsApp group either. No, you're not. So we can add you to our WhatsApp Bosom Buddy group as well. Okay. Great. Okay, I'll send you my number now in the chat. Anybody else?
Tracy here.
Yes.
Sorry, I'm not sure whether you'll be happy if I share it, but it is a really good support group called Wings of Hope Cancer Support.
Sure, absolutely.
There are branches throughout South Africa. They have a Facebook page, but they also have WhatsApp groups for the different areas that you're in. But have a look at that. They are phenomenal. It really is. And it started off being a support for breast cancer. And Nursing, who happens to be the chairperson, is actually a male who has had breast cancer. And just joining the group, you will learn so much. It is really, really fantastic.
Absolutely. There's lots of groups out there, and we all appreciate each other and all the different groups. So 100%. Okay, anybody else with questions for Gabby? Exercise related, occupational therapy related, treatment related?
Wait, Gabby, can I just ask you one thing?
Sure.
With the reconstructive surgery and the reconstructive surgeons, and obviously with the different types. So, I mean, you know, you're either having implants or expanders, or, you know, some of the more radical treatments, you know, the tram flaps and the lat flaps and all of that. Because I mean, that's like another whole story with
with rehab, completely,
and healing. Because I mean, you know, they need even more rehabilitation and support, and take a lot longer to heal. So I mean, I think that's also, and I just hearing different stories from different reconstructive surgeons. You know, my reconstructive surgeon was very chilled, and you know, he was very happy to let me exercise quite soon. You know, obviously within my capabilities. And then you hear of some of the surgeons that are extremely conservative and will say, you know, you can't do much, you know, almost like a year. I mean, I know everyone's situation is different.
So that's it. I think each physician is so different in their own practice, you know, and some will say, let's be extra and overcautious so that patients don't come back with like a secondary complication. But you know, physically speaking, for patients who have implants put in, essentially what needs to happen is a capsule needs to form around that implant to attach onto the pec wall. Now that capsule takes up to a year to form properly. So, you know, generally plastic surgeons don't want them doing any vigorous exercising like running or boxing or jumping, because then you're shifting that capsule in that movement. Others say that if you've got support, if you've got proper support on, then it should be fine. You know, you're holding the breast in their position, nothing's going to happen to them. We see a lot of the time, though, patients who have implants put in and then have radiation, something called breast encapsulation. So what happens is that capsule that's meant to form over the breast, instead of being good, healthy tissue, becomes scar tissue, and the breast becomes, you know, really hard. You've got to massage it and break it down before it can get to an irreversible stage. So it is completely dependent on each case. You know, if you've got your expanders in, the purpose of those expanders is to make space for the implants. You know, you go and have them filled up, and again, they're in a pre-designed pocket from your plastic surgeon or your recon surgeon, and any, you know, kind of viscerous exercise can shift that out of its pocket and cause complications later. But the implants and the expanders themselves can take quite a bit of force. You know, patients shouldn't be too worried about eventually sleeping on their side, or years down the line, patients do, you know, get to sleep on their tummies and on their breasts and things like that without that discomfort. But I think it's also, you know, about making patients aware that it's not just a quick fix surgery. You've got to be quite protective, and you've got to be quite thorough with your care, your follow-up care for about a year after treatment, as you say. But you know, what's quite interesting, Nicole, and I'm glad you brought this up, is that we have surgeons and we have doctors that are still practicing in old medicine. We're seeing patients coming from countries in Africa where they've just said, okay, no, double mastectomy, no recon, or we're doing this and this is kind of your only option. And I know Prof is quite thorough about this with her patients, and that surgery is a choice. You choose to do it. There are, you know, in some cases, unfortunately, one route, but a patient needs to be explained that it's due to the, you know, pathology of the cancer, that this is why it's a mastectomy, or this is why it's safe to do just a lumpectomy, and we're not taking more than 1 or 2 nodes and things like that. But the biggest thing that we worry about with the implants is just the encapsulation. And surgeons, especially, you know, your recon surgeons are quite perfectionists. They want you to heal nicely and properly, and they worry that if you're too mobile too early, then there's a breast discrepancy either in size or healing or things like that. But from a health-wise perspective, to be active is to be healthy.
You know, saying that, you know, with patients, you know, not really knowing much, and to say again, I think it's such a valid point in bringing in navigation and making patients aware. You know, I mean, as we all know, from diagnosis at the beginning, and having navigators in with oncologists or surgeons when they're discussing. I mean, we all know how busy they are. We know how busy Carol is. You know, her time is so limited. And I mean, she's really brilliant. There's some that just don't give their patients enough info. 100%. And I think it's, you know, it's so important to try and push navigation from, you know, even the like early consults of diagnosis, and then to, you know, be able to say to the patients, this is what you can experience, and this is why you're having a mastectomy without recon, or you're having whatever.
Navigation is I think it's one of the most powerful tools that we have in our centers, is that we, like you say, you've got more time than the treating physicians to actually sit and explain with the patients, and the patients end up having so much confidence not only in their doctors but in the treatment process in a whole, because they're prepared for what's coming. And I think in something that I mentioned earlier with that concept of prehabilitation, navigators should be at the forefront, driving that prehab, driving, this is what's going to happen to you, this is what you need to expect. I think it's as you say, it's just not, if not more important, to have the navigators there from the beginning.
Yeah. Thanks, lady. Thanks, ladies. We definitely think navigation is very important. But that might just be because we are navigators, but we love to explain everything that happens to patients, and really hope that in the future that everyone can have access to patient navigators. Kourie asked an interesting question, and I wonder if you should explain it, Kim, because you might be able to explain it better than me, with muscles kind of in mind. Are there other reconstructive options besides implants? I'm not too sure how much you know about like the Goldilocks procedure at Helen Joseph. You might be the best to explain it.
Did you say I must explain it?
Yeah,
okay, yes. No, look, there are multiple options. So again, based on the size of the tumor, the location, the pathology of it, if there's lymph node involvement, these are all kind of predisposing factors that determine the surgical procedure. So you've got your lumpectomy, which is just the removal of the cancer itself. Sometimes patients have what we call therapeutic mammoplasty on the other side, so that their breasts are equal in size after they've done the lumpectomy. You have your mastectomy, and the option to put implants in, the option to put expanders in, and then have implants in at a later stage. Jenna mentioned something, what they call a Goldilocks procedure. Essentially what they do there is they use tissue from your own body. They bring flaps down from your chest up into the breast, and then close the breast down around them like that. It's called the Goldilocks procedure because it's the just right procedure, as the Goldilocks, story goes. I remember they used to do Goldilocks quite often, but now, they're moving along with something what we call a wide local excision, which is essentially removing the cancer and then reconstructing the breast, if there's enough tissue to work with, essentially. So there are other options other than just using the prostheses and the breast implants. We have some patients who just say, I don't want anything, you can just leave me flat. That's of course an option as well. There are alternative kind of prostheses that you can use externally. So some women purchase bras that have fold out cups already on the one side to match their breasts. There's an initiative that runs at Helen Joseph called Knitted Knockers, where they have knitted kind of, it looks like a breast that, you put in your bra, and when you're wearing clothes, everything looks even. So there are options from an aesthetic point of view, but also from a recovery point of view as well, to suit the patient specifically. And I think it's very important that you speak about these with your treating surgeon, so that they know that you are empowered and you know what options are out there, but also that you know that when they tell you this is what they need to do, that they're telling you from a reason. They're practicing good medicine, essentially.
Okay, great. Thank you so much.
Sure.
Ladies, who else has questions for us? Questions about any kind of exercise, anything you've been battling with? What did you battle with from a functionality point of view? Claudette?
Yes.
Yay, okay.
Okay, my question is, I had a lumpectomy. I had my lumpectomy the end of January, and I started chemo in March. As a result, I've got a lot of scar tissue. What can I do to ease the pain of the scar tissue?
Okay, so where is it? Around the breast? Claudette, are you saying you've got scar tissue around the breast area?
both, yes.
Okay, so what you've got to do essentially, to treat that is scar massage. So you've got to make sure that you're breaking down those scar kind of fibers in the breast. Muscle grows, if muscle grows longitudinally this way, scar tissue tends to attach this way and it's interwoven into the muscle. So that's why it often has a funny texture and it's painful when you touch it. So scar massage, the best kind of mechanism to use is a circular motion. So if you can get your thumb to do kind of like a crisscross or up, side, down, side like that, you're going to rub over the same spot 4 times and move across that scar line. But you've got to press quite firmly. So it is going to be painful initially because you're physically breaking down that tissue, that scar tissue below the skin. Secondly, you can treat it topically. So with oil, I know some people are for bio oil, some people aren't. I use bio oil every day, so I'm a fan. There are other creams out there like scar science creams, but your 2 main kind of treatment points are going to be massage and compression. So if the region of scar tissue is small enough to use micropore is like a compression tape that they use post-surgery, but you can use it for years, on top of scars to push that scar tissue down. You can purchase them from any Clicks, Dischem or pharmacy. It comes in a small, if I'm not mistaken, purple and white box just called micropore. Or alternatively, if the scar tissue is really bad and you're experiencing what we call like a hypertrophic scar, where the scar tends to expand outside of its borders, not keloid, it's kind of the step before keloid, then we can look at things like compression bandages and compression garments, where you would wear kind of like a boob tube compression garment over the chest, just to keep that scar tissue at bay until you kind of sort yourself out.
Thank you.
So welcome.
Great. That was really, really interesting. Thank you.
Sure.
Okay, ladies, who else has questions? Lou, you haven't asked any questions today. Normally she's the one with 5 million questions. Anybody else with questions, any particular things that they...
There's Lou.
Lou, you have questions now.
Sorry, I've got bad internet connection today, so you keep coming and going.
Sorry, Lou.
It's fine. So, do you want a question?
Yes.
Yes, please.
That tight band under your breast after surgery, how do you get rid of that feeling?
You've got to do trigger point. You've got to do trigger point release. So you've got to actually pick up the muscle, find the trigger point in the muscle and push it, forcing that muscle to relax. You're in a state of constant inflammation otherwise, that muscle is so tight. So if you give a patient steroids or anti-inflammatories, it's going to help, but it's got to be continuous kind of release of that muscle. So you can do it through stretching as well. You can do it through nice prolonged stretching, but you've got to make sure that you're targeting that pec muscle because that's where that tight band is pulling from. There could also be, it's muscle and neural tension essentially. And then with that, you get complications of, the pins and needles because that muscle's compressing on your nerves. It's compressing on your lymph nodes. Some patients experience swelling on the chest sides here, under the arm, because it's just pushing down on all structures there. So we've got to really release that muscle and get it to a point of relaxation.
Okay, so what's the better option, OT or physiotherapy?
Anyone who's trigger point release trained. So both are. So if you've got your physio, you've got someone at hand, you phone them, say this is what you're experiencing. If they can't do that, then go for it. Go to your physio. It's just about going to someone who's just trained correctly more than anything else. See, our scopes overlap quite a bit. It's just that occupational therapy, we treat through function. Physiotherapy treats through mobility and muscle strengthening and things like that.
Thanks.
So that's our main difference. Sure, Lou.
Cool. We did have a question on our WhatsApp group during the week about what's it called when the veins go hard?
Coding.
From chemo. Yes. Do you want to chat about that a little bit? Because I don't, yes, coding.
Is it coding?
Yes. Because I don't know if everybody knows about it and I find it very interesting.
So cording is essentially what we call medically axillary web syndrome, and it's a sign that your lymphatic system is under strain. So generally women start to see, it looks like guitar strings running down their arm here, and then it presents in your cubital fossa and your elbow over here as well. All that is, again, is you need to have tension release in the arm. So your lymphatic system is either under strain. A lot of women experienced it after getting their vaccines. So just a heads up that, you know, if you've had lymphs removed from your left or your right side, let's say, for example, on your left, you need to be very careful of procedures that occur on the left side. So all blood should be taken from the alternative side. Injections, vaccine should be given on the alternative side. Even going to check things like blood pressure should be done on the side where nodes weren't removed, because it's going to aggravate your lymphatic system and it might cause a bit of a backup. So women present with that cording quite often after surgery, because there's been a lot of movement around. That's kind of when your lymphatic system is adjusting to the gap now in your circuit. And it's a warning sign that things aren't working well in your body and you need to do manual lymph drainage, but also just basic maneuvers and exercising to release whatever muscle band is pushing on that system there. So it's not something life-threatening, it's not something irreversible. It's almost your body saying, whoa, I'm not coping, you need to help me push this lymph fluid elsewhere in the body.
Okay, great.
Ben, can I just say something here with auxiliary web syndrome? You know, they also don't tell patients that so often.
No,
I actually developed it, and my plastic surgeon said it was from my sentinel lymph node biopsy. It wasn't from him doing the surgery. And I mean, luckily, I mean, I didn't even know what it was, and so I just left it. And I mean, I was exercising and doing everything, and it just disappeared sort of as quickly as it came. It lasted a week or two, and then it just disappeared. But I think that's something, you know, we also need to make clear. You know, we always talk about lymphedema, and then we don't mention auxiliary web, you know. And I think we also just need to remember it, because I think we tend to forget, hey, Jen?
Yeah, absolutely. Lou, did you have a question?
There's another problem that a lot of the patients get while on chemo, and this is neoadjuvant a lot of the time, where the vein actually shrinks. Okay, and they get it confused with cording.
Yes.
And even the oncologists go, no, what's wrong? Where you actually can't stretch your arm. It feels like an elastic band pulling in it. And that's very different to cording.
Yes, no, completely. Like, as you said, Lou, that's a completely different cause. So that is often more the breakdown of your blood vessel wall, you know, from having chemo run through it so frequently. And it causes quite a bit of muscle stiffness and muscle ache. I mean, you know, if you go for a simple blood test and the nurse misses your vein or really struggles to take blood, you feel quite a bit of stiffness for a day afterwards. It's very difficult to move and get your arm out in that position. A lot of patients opt for ports nowadays. I know it's an extra procedure and it is an extra expense, but it's a lot easier to just kind of have something to tap into every time you go for chemo, if that option is available to you. For most patients, though, unfortunately, it's not. But if you are doing just intravenous, it's to make sure that while you're having chemo, you know, you've got your hand on something comfortable, something warm to help expand and have those blood vessels pop up, and to try alternate arms every session so that you're not going into that same streamline all the time. Unfortunately, what Lou's talking about is unavoidable in most cases. The veins, you know, your vein strength, if those vessels haven't collapsed completely, they can improve with time post chemotherapy. But that tightness is just an unfortunate side effect of the chemo itself. And like Lou says, not to be confused with cording and axillary web syndrome.
Absolutely. Okay, great. Thanks, Lou. Anybody else with questions?
So I battled to get in this morning. I don't know why. I've been trying since 11 o'clock to get in.
Oh, no, sorry.
I want to say I had a port the second time. I've had cancer twice. And the second time I had a port was I've actually got lymphedema in my left arm. So I can't have any injections, nothing in my left arm. So everything's got to be done in my poor right arm, vaccinations, everything. So I had a port the second time. I must say it was much better. But of course, you can't have blood tests done through your port. It's only for the chemo. I thought it was for all blood tests, but it's only for the chemo, unfortunately.
Thank you for
Great.
that, June. Thank you.
And I'm glad that you finally were able to join.
Thank
Gabby,
you.
do you maybe just want to touch on lymphedema?
Please, yeah.
Yes, with pleasure. So lymphedema essentially is a buildup of your lymphatic fluid due to a multitude of reasons. So some patients present with lymphedema early in their cancer diagnosis. If your cancer has spread to your axilla and your nodes are enlarged, it's going to put strain on your lymphatic system. Most commonly, though, it occurs post-surgery. So what happens is you can imagine you've got your lymphatic system running all through your body, like a network of roads, and all of a sudden there's now a gap in the roads. Fluid is going to get there and there's nowhere for it to go, and it's going to start building up. And that is essentially what lymphedema is. It's trapped lymph fluid. Now, modern day technology and how Professor Ben operates, she doesn't put her patients at risk for developing lymphedema. Back in the day, they would go in and extract 17 or 20 nodes, and then the patient would unfortunately be at risk immediately for developing lymphedema. Now, with smaller amounts of lymph nodes being taken, we're not seeing it as commonly, but it is still a possibility post-surgery. So how we treat it is to catch it nice and early. If you present in an early stage, like stage 0 or stage 1, it can be reversed. If it is stage 2, stage 3, then it becomes a lifelong kind of treatment of manual lymph drainage back in the body. So we physically push the fluid elsewhere so that it drains in nodes that can kind of take that lymph load. It is wearing compression garments constantly to stop the fluid from kind of sitting either in the chest, axilla, or trunk of the arm. There is warning signs for lymphedema. So 4 kind of notable signs that you'll experience. Number 1, you'll visibly see swelling in the trunk of the arm or on the chest cavity wall over here. Number 2, the arm will feel very heavy. So when you try and lift it just normally, to put a top on, it will really feel like gravity's pulling that arm down and you've got to do quite a bit of extra work. Number 3, you might see a bit of the cording under the arm, that axillary web syndrome that we discussed. And number 4, your clothes will start to fit differently. Sleeves will be a lot tighter on one side than they will be on the other side. And that's your body giving you the warning signals of that, there's lymph buildup, we need to drain it. If it's caught early, as I say, we can reverse it, but it's also important that even if you do have lymphedema, to continuously go for manual lymph drainage. Whatever your lymphatic system is draining from your other circulatory systems is kind of byproducts of that. So if it sits, it can become quite life-threatening. We used to see patients that would come very late for treatment, and at that stage it would almost be, we can't do anything. But now that there's so much awareness out there and there's so much that is available in terms of treatment, we're seeing less and less patients impacted by it. But if you are experiencing swelling, it's very important to find either occupational therapist or physiotherapist who's lymphedema trained, chat to them about your symptoms, and then they will prescribe a treatment plan for you for that. June, it's nice to see you wearing your sleeve, being nice and compliant.
This is my night sleeve, actually. They call it the dinosaur arm. I actually go to Bryony Crickler in Rosebank Physio every Monday, every week, should I say, for treatment. And I'm with Discovery, and you have to have it motivated.
Yes.
They pay for about 12 sessions at a time. But before this time, they had to send 3 lots of motivation letters because they refused to pay for it. And I've got an oncology limit of 400,000 a year, but then they agreed to it. But every sort of 12 weeks, you've got to keep on motivating for another one. But what actually happened, I had mine done through Caroline Ben and Marissa Fenter. What's her name? I can't think. Marissa Fenter. And then I had the lat flap done, and they took the nipple off. And then I went to another plastic surgeon at what's her name, Carla Norville, and my scar didn't heal well, and she fixed that up, but I think she must have touched on the lymph nodes, because since then my arm started swelling a little bit. Yes. And then I had cancer again in 2019, and I had to have the right side done. And then last year, just before lockdown, I had to start my radiation after I'd had the mastectomy and the chemo. And after the radiation, my left arm, where it had swelled a little bit, it's got out of control now. And ever since then, a battle to get it down. It's much, much more swollen than it ever was. And I don't know whether it's caused from the radiation. Dr. what's his name? Radiologist at Donald Gordon. I can't think of his name. But he said it's not from that. Professor Demetrio said it could be from that, but it's impossible to get out
I'm
the
glad
top
that you,
of the
that you
arm and the
touched on
lower
that.
down.
I'm glad that you brought up radiation, June, because sometimes patients are fine post-surgery, and then the main cause or main result of radiation is inflammation of that muscle. So again, you got that compression
Maybe
pushing
that's what
down
it is,
all of your
yes.
nose, and it can trigger lymphedema. If
But
you
I'm
are
very lucky. I don't have
separate.
any pain and I don't have any heaviness. It's one thing. But of
That's
course, the
good.
swelling, I've had to get rid of a lot of my tops. And what
Yes.
it's these compression sleeves, they don't last very long. And
No.
they're terribly expensive. They're about 2,000-3,000 Rand. The night sleeves about 4,000 Rand because they all come from France or Germany. And they don't last forever. You have to keep on replacing the day sleeves, I'd say every 6 months actually, and the night sleeve maybe once a year. But it's ongoing all the time, you know. That from that point of view, it's a pain. But luckily, I don't, you know, feel any pain on the arm. Thank goodness, you know.
Good, good. I'm glad to hear that you're not in pain.
Yeah, that's one thing I can be happy about. Did the session
Thank you
start
for
at
that.
11 or did I miss it?
No, it started at 10, but what I'll do is I'll send you
Oh my God, I thought it started at 11. Oh my God,
no,
sorry.
it starts at 10, not at all.
Sorry.
I'll send you a link to the recording, okay, June, so you can
Please, yes.
then
Sorry.
just
Oh,
watch
God.
what you've missed out on. Any other questions for Gabby?
Can
While
I
we
do
have
one
her
more,
here-
please?
Yes.
The peripheral neuropathy, whatever neuropathy.
Neuropathy, yeah.
Yeah. I had it in my fingers, but that's all sorted. That just went quite nicely by itself. But from my toes to halfway under the arch, irritate me 24 hours a day. Does that disappear, or is it something I'm going to have to just get used to?
So it's very difficult to say. There's really not a lot of research. Sorry, my dog is snoring.
That's
and
fine.
can't reach
My
her.
dogs and cats were fighting just now. So.
So it's, you know, there's very little research into nerve kind of redevelopment and nerve conduction and things like that. But there are various therapies you can try. So I know generally doctors will prescribe something like a Lyrica or a Neurobion, a vitamin B12,
Yeah,
just to kind of
Lyrica.
to kind of get that nerve pain under control. So essentially what
Okay.
Lyrica is, it's a type of a nerve block, so you don't get that sharp shooting pain continuously.
Oh, okay.
Something
That's
that
probably
we
why my
use-
hands are fine now.
yeah. Something that we use quite often, and it's going to sound strange, we call it a rice box. So essentially what you do is you fill a Tupperware or tub of rice or anything similar in that texture and put your feet in it. Put other objects in there like marbles, coins, anything small, and get your foot kind of desensitized to those different types of textures. It works better in the hands, obviously, and it touches into other kind of nerve concepts, but it desensitizes those nerves at the bottom of your feet. Do you walk barefoot often?
I normally do, yes. I work
Okay.
from home, so I don't have to put shoes on.
Oh, lovely. So, you know, walking barefoot has its health benefits, but unfortunately for your nerves, you're exposing them to a wider variety of varying sensations. So you've got different textures, you've got different temperatures, whereas if you're in a sock and shoe, you've got that consistent kind of temperature throughout the day, consistent texture. And then from a sensory aspect, you're not going to get that tingling all the time because your nerves aren't being stimulated. So
Okay.
it's about just dulling them so that they're not taking in a sensory overload until they can basically kind of organize themselves and regenerate the information that they're getting from their environment back into the body without being in constant, you know, like fight or flight mode.
Okay.
Yeah.
Maybe.
That makes sense. Thank you.
Can I just quickly ask you, you know, there's
Yeah.
been some of the courses I've done that for peripheral neuropathy is while patients are actually having chemo is to put your feet and your hands on ice or in cold compression, and then it or cold, you know, something with ice packs or those those gel ice packs and things. I mean, do you think that works? But I mean, because you also don't want to have too cold, because then that can also cause damage for too long. Yeah.
So essentially what you're doing with the cold is you're constricting blood vessels in those areas, so there's less blood flow, so your chemo is not traveling up to that area of the hand or the feet. I know there's something that some oncology units use. It's called like a cold cap. What they do essentially is basically put it on your head. It stops the chemo from going up to hair follicles and stops hair loss and things like that. So basically what you're doing is you're just preventing blood flow to your extremities, and then you're not getting that kind of sharp nerve pain during chemo or after chemo. It does work for some patients. Some patients say, you know, they want the chemo to travel everywhere. Very much a subjective choice, but it doesn't prevent neuropathy from occurring afterwards. Lou, do you have something to add?
I had ice packs in my hands and feet, and I even tried the cold cap, but my hands and feet definitely got peripheral neuropathy. They've never felt the same. They feel like prickly all the time, but I suppose you get used to it, but sometimes it feels worse than the other. The cold cap I tried about 3 times. It was in midwinter. Eventually I couldn't bear it any longer. I felt so miserable. It was a miserable day, and eventually I thought, no, I don't care. The second time I didn't lose all my hair, but it got very thin. So I thought, no, it's too bad. I wasn't prepared to put myself through that agony. But the hands and feet, unfortunately, never worked with me at all.
Yeah. Lou, you had your hand up.
Just to comment, just to comment about cold caps. The medical aids generally don't pay for it.
Yeah.
I have not with me at Donald Gordon. They gave a trial. That's why I didn't pay. Yeah.
They, I have not met a single patient who hasn't lost the majority of their hair, even with a cold cap. Okay, so if you like your head being frozen, great, but the reality is
very miserable. Let me tell you, it's terrible.
You're still going to lose your hair.
Yeah, it's not worth it, quite honestly.
Oh, well, I didn't say it.
Okay, Lorraine.
But you're muted, Lorraine.
I've asked you to unmute. I don't know if you, there we go. We still can't hear you though. I'm not too sure why. You're battling with sound today. Do you want to type it in the chat, Lorraine? Or is it too long to type in the chat?
Question so long?
Yeah.
Okay, I was at the specialist last week and they discovered that I have a heart problem due to the chemo. It's causing my feet to swell and my cough and the whole tutti. I want to know what can I do to help with the swelling of my feet, because they've got me on water tablets, which is helping, but I still have terrible pain in my feet. What
Puricos.
For that?
So I'm jumping in here, but I also had that, and they've diagnosed it as being like gout, and I've been given Puricos, and that's helped me. But you have to take it every day for like ever.
So Tracy, Puricos is specifically for gout buildup. So it's fantastic. I know I was on it during my chemotherapy as well. But if Claudette is experiencing swelling, hers is more edema. So it'll be more related to her heart condition, different to gout. So I would check it, rather she check with her physician and discuss that she's heard through a support group that your, fellow patient is on Puricos. Would it be helpful for her to take it? But if it's more cardiac edema, Claudette, what you're going to do from home for us is essentially you're going to keep your feet elevated. So we want your feet at a gradient where your head is below, so you're angled. That sounds ridiculous, but all you need to do is just stack up 2 or 3 pillows and get your feet above your head. So that will promote kind of drainage back into the body. And then you're going to do compression wrapping. So very easy, just buy a bandage from your pharmacy or from a Clicks or Dischem and wrap that around from your knee going down towards your ankle. just to kind of also compress and push any fluid that's sitting in there back up into the body. I'd also just watch diet and what you're eating then. So salt is quite a big, fluid. It promotes fluid retentiveness. So I would stay away from salty foods, and it should just ease up over time.
Great. I hope that helps, Claudette, and otherwise you can have a nice long chat with Gabby one day in the clinic when you come visit us. But I think that when you come visit us, so I think that will help in the meantime. Thanks a lot, Gabby. Lorraine,
yes.
I had a
I'm
lat
just
flap
reading the
bilateral. How does the steel band last? How long does the steel band last? Totally no feeling in the back and breast. Difficult in movement, e.g. cannot get up from the floor and battle with exercise. Thank you.
So with the flaps, yes, thank you for your question, Lorraine. Interesting and brilliant to see how far you've come from the surgery. That's amazing. That tight band is just, it's muscle stiffness, but it's not superficial, it's deep muscle stiffness. So again, you need to go for some sort of muscle therapy relief, whether it's manual manipulation, whether it's massage, and you can, access those kind of resources or therapies at a physiotherapist or occupational therapist that is trained in that region. The feeling that you have, or rather don't have, in your back and your breast, essentially when they do the flap, sometimes nerves and things get cut and patients lose that sensation integration to the nerves. How long ago did you have your surgery?
Hold on, you said earlier, hold on.
Was that
7 years survival bilateral.
Oh, brilliant, 7 years, okay. So it is unlikely that sensory integration will ever return, that you'll have sensation in the back and breast, because that supply has been cut when they moved the muscle up to do that flap procedure. Getting up from the floor and battling with exercise, is that even, getting up from the bed at night as well? Or is it when you're doing kind of core exercises? Okay, so remember, you've got decrease in your structural muscles in your abdomen and in your core and your trunk essentially now. So it will be difficult. You will have a bit of pain because you have other muscles compensating for the lack of. But what I would recommend is to just kind of find someone who you're able to reach out to, whether it's a physio or an OT, that can prescribe specific exercises that you should be doing to strengthen your core and remaining muscles to compensate for that lack of in that side. But I'm sure that's quite frustrating to have difficulty and not to be able to do things that you would have prior. Okay. So I think let's get you sorted with an exercise program.
Great. Yeah. I know Lorraine isn't in Joburg, so we can maybe try and help her find someone that side. Yes. Otherwise, I don't know if you do online consultations, Gabby.
So I do, but in Lorraine's session, she'll need a bit of manual manipulation and things like that. So I'm going to pop her a private message, and then I'll source someone in your area that is trustworthy and someone who we can send you to for a session.
Oh, yay. Great. I'm excited for you, Lorraine. I live in Howick.
Oh, fantastic. Okay, that's perfect. I'll do my homework, Lorraine, and I'll find someone to send you to.
Great. Thank you, Gabby, and thank you, Lorraine.
Awesome.
Ladies, that just made me so happy because now Lorraine is going to get sorted. Ladies, anyone else with questions for Gabby? No. We've had quite a nice long session today. It's been really, really good. Gabby, thank you so much for joining us.
Thank you for having me. Thank you.
Yeah, really, really informative. Yeah, so thank you.
Awesome.
So interesting, so informative. I think everybody enjoyed it. And Gabby is at Mill Park and sometimes joins us at Helen Joseph as well. So if you ladies want to get in contact with her directly, let me know. And I will put you in contact. Oh, Lorraine just asked, how long should one be on tamoxifen? Your oncologist should tell you. It depends, I think. That the best question to be asking your oncologist. I think it's between 5 and 10 years. Lou?
17 years ago, because that's when I had breast cancer. The standard was 5 years plus 2. It has subsequently changed to 10 years. Now the latest recommendations are lifelong.
So Lorraine was taken.
I'm sorry, that didn't answer your question, Lorraine.
No, it didn't. She was taken it off 6 months ago.
Because I saw an ASCO recommendation, one of those ASCO guidelines, and they said it also depends with tamoxifen whether you're pre or post-menopausal. So
Yeah.
I mean, that can also influence. But I mean, Carol said to me, you know, and George, Prof. Demetria, that, you know, especially if you've got high estrogen assay, which means your, you know, that your estrogen levels on your original tumor was so high that it can, you know, they're looking at life now. That's what
Okay. But just remember that most women on tamoxifen are perimenopausal. Okay. The younger woman, or the women that were diagnosed at a younger age, like myself and Omar and those sort of things, have been put on other AI and aromatase inhibitors. Okay, so tamoxifen is generally peri or postmenopausal. If you are very pre, then you go on Zoladex, Aromasin, the injection and those sort of things. So each person is different, but if your oncologist could, they would leave you on tamoxifen indefinitely because it has long-term benefits.
My cancer came back. I took tamoxifen after my first one in 2014, and my cancer came back in 2019. I spent the whole time on tamoxifen. Now I'm on Laradex. That's a generic of something else, but it's a generic of, I can't remember the name. So it didn't help me at all.
No, June. It did help.
Oh, did it?
It did help because if you weren't on it,
it would
have recurred at 18 months.
Oh, okay.
Or earlier.
I suppose it's one way to look at it.
So yes, it did help.
Yes.
And I mean, it's one of the oldest, it's a chemotherapy drug in theory. It's one of the oldest drugs in breast cancer, and it still works.
Okay.
So, you know, you can take a headache pill. Doesn't mean you're not going to get a headache. But if you get the headache, it won't be as bad.
Yeah, my second one wasn't as bad as my first one. Yeah.
Well, there we go. It's because you were on tamoxifen.
Yeah. And also the oncologists say that, you know, sometimes it's very good to do a switch after 3 years. So if you're on tamoxifen for 3 years and then they switch you across to an aromatase inhibitor, that's what Prof. Demetria's, you know, and I mean, a lot of the research says. So, I mean, but that also depends on individual, how you handling side effects on each of the different, you know, of the different ones. But they often do suggest a switch after a certain amount of time.
So I'm sorry, Lorraine, we didn't really answer your question. Because, but you were taken off 6 months ago, but I'm sure if your oncologist seems that it's perfectly okay that you're taken off tamoxifen and you carry on with your checkups, etc., then you trust your oncologist and you go with the doctors, with what your doctor says. Hopefully I know some ladies absolutely hate tamoxifen and have a lot of side effects with it. So we'll hope that it's the best kind of choice for you. If you're questioning it, then maybe chat to your oncologist about it, have another appointment and talk to your oncologist. Okay. Yeah. Thanks, Lorraine. Otherwise, ladies, no other last questions, comments, questions? I don't think so. Thank you very, very much for all joining us today. I think it's been a really, really great, informative, interactive session. What I do want to say is that we are in Johannesburg at least starting some monthly walks. So I think this fits in quite nicely with
Very
this. Yes, Lou,
nicely.
don't hide, you coming with. This fits in quite nicely with this session. We're starting in Joburg because majority of our patients are in Joburg, but for anyone that is kind of in other areas, if you have a group of survivors or family, then you can join us in your area on that particular day and have little satellite walks kind of wherever. So the idea is the first Sunday of every month, we'll choose a venue, a kind of a park runish venue, and we'll go for a walk. So anyone that wants to is welcome to join us. Our first one is going to be on October 3rd to start our Pinktober. Lou, I haven't chatted to you about it, but I thought Delta Park was a kind of central location for everyone in Joburg, and we could start at Delta. And it's just getting together in the open air, being socially distant and all of that good COVID kind of stuff, and seeing each other in person, which will be absolutely amazing, and having a nice walk and socializing. So we're really excited about starting that. If you'd like to, then come and join us on October 3rd. I will send more details and all of the details via email, WhatsApp groups, etc. Okay. Otherwise, thank you very much, ladies, for joining us. And hopefully we'll see you all at our next Bosom Buddies meeting.
Thank you. You'll send me the link so I can listen to the recording.
I will send you the link. Yes, Lou, boss lady?
Just in case you struggle with walking far, that is part of the aim of the object. But I think a lot of us are starting to feel very isolated and alone. And this is a way for us to get together without breaking all the protocols that we're supposed to do for social distancing. Vaccination, please vaccinate. It saves us and yourself. But this is the only way we can realistically actually get together and have a community within ourselves. So whether you want to walk or don't want to walk, it's fine. But I think it's about a place that we can get together, walk a half a kilometer, turn around, walk 10 kilometers if you like. But it's just a nice way to start interacting again. Yeah.
And being COVID friendly out in the open air.
Yeah.
Okay, great. So those will all be kind of very informal, casual sessions. And I think we might do a different venue every time to keep it exciting, or we might keep it the same, depending on how it kind of goes for everyone. It's very much a take it as it comes and adapt it to what works for everyone. So hopefully we can see some of you ladies on October 3rd. For our ladies that are far away, I'm really, really sorry. We're going to miss you. But you can have a walk in spirit with us on that day. Have a walk and we'll video call you or something. Okay, so thank you for joining us, ladies. It's been a nice long session today, and I hope you all enjoy the rest of your Saturday and have a great weekend. And special thank you to Gabby.
Thank you, guys. Thank you for having me. Thank you, ladies.